This week, my flashcard is on Crohn's disease. So, Crohn's disease is a chronic, relapsing, remitting inflammatory disorder that can affect any portion of the GI tract. It most frequently involves the terminal ileum and proximal colon. It is characterized under the umbrella of inflammatory bowel disease alongside ulcerative colitis, but it is distinguished by transmural inflammation and a patchy distribution of lesions that are often referred to as skip lesions, with normal segments interspersed between inflamed areas. The inflammation can result in complications such as strictures, fistulas, and bowel obstruction. It often progresses from an inflammatory phenotype to a stricturing or penetrating form that causes significant morbidity and potential disability over time. It's systemic in nature, and it's capable of producing extraintestinal manifestations that could involve the joints, the skin, the eyes, or the hepatobiliary system. Now, in a healthy individual, the GI mucosa functions as a tightly regulated immunological and physical barrier. Intestinal epithelial cells, goblet cells, and Paneth cells coordinate to produce a protective mucus layer that secretes antimicrobial peptides and maintains epithelial tight junctions. Beneath this barrier, the innate immune system, which is macrophages, dendritic cells, and a pattern recognition receptors, like toll-like receptors, respond to microbial antigens with controlled tolerance, limiting inflammation and preserving mucosal integrity. Regulatory T cells maintain immune homeostasis by suppressing excessive inflammatory responses, and the gut microbiota provides beneficial metabolic and immune modulating signals. Now, in Crohn's disease, the pathophysiology reflects a breakdown of intricate balance that's different than that of a healthy individual. Genetic polymorphisms, particularly in NOD2 and FUT2, compromise mucosal defenses and innate immunity, which leads to impaired bacterial clearance and defective mucus production. As a result of this, the intestinal immune system mounts an exaggerated response against commensal microbes. The normally protective role of the T helper cells becomes pathological as Th1 and Th17 cells become overactive and secrete high levels of pro-inflammatory cytokines. Those cytokines then amplify the recruitment and retention of immune cells in the intestinal wall. This process is further fueled by the overexpression of adhesion molecules, which are rarely upregulated in a healthy gut. As inflammation becomes chronic, extending through all layers of the bowel, it promotes granuloma formation, fibrotic remodeling, and extracellular matrix degradation by enzymes like MMP1 and MMP3. Unlike in a healthy intestine, where inflammation resolves and tissue regenerates effectively, in Crohn's disease, the caused repeated injury and abradant healing. This then leads to strictures, fistulas, abscesses, all hallmarks of the disease, penetrating, and a fibrostenotic behavior. The functional consequences is impaired nutrition, increased gut permeability, and dysregulated motility, which manifests clinically through chronic diarrhea, weight loss, and abdominal pain. Several risk factors are associated with Crohn's disease, such as genetic predisposition. This is especially seen in mutations in NOD2/CRD15, which are linked with ileal disease and early onset, aggressive Crohn's disease that these often require surgery. Cigarette smoking is one of the most consistently identified environmental risk factors and is also linked to higher rates of disease flare-ups, surgery, and reoccurrence. Also, a westernized lifestyle, urban living, and industrialized environments are also linked as risk factors, likely because of the changes in diet and microbial exposure. Dysbiosis of the gut microbiome contributes by altering the immune response, facilitating bacterial translocation, and triggering chronic inflammation. So, previous infections, such as use of NSAIDs and physiological stress that can disrupt this, have been considered somewhat modifiable risk factors. A combination of these influences leads to loss of tolerance to gut antigen and promotes immune-mediated injury. The clinical presentation of Crohn's varies based on the disease location and severity, but common overall symptoms are chronic diarrhea, abdominal cramping, specifically the right lower quadrant, fatigue, weight loss, and low-grade fever. Now, diarrhea results from mucosal damage and increased intestinal motility due to inflammation. Ileal involvement often leads to vitamin B12 malabsorption and megaloblastic anemia. Anemia can also arise from chronic blood loss due to ulceration and melena. Systemic features can present, such as anorexia and fatigue, that stems from malabsorption and the catabolic effects of systemic inflammation. Extraintestinal manifestations can include erythronodocism, arthritis, and uveitis, which are all linked to immune dysregulation. Complications can occur, such as fistulas, strictures, and perineal abscesses that develop from transmural ulceration and healing by fibrosis. In children, it can be seen as growth failure and may be an early sign, and that's all due to the protein calorie malnutrition and corticosteroid use. So here's a picture of some of the common signs, such as loss of appetite, fatigue, fever, mouth sores, diarrhea, stomach aches and cramps, blood in the stool, and weight loss. And then here's kind of a comparison of IBS versus Crohn. IBS is classified as a syndrome, and it does not cause inflammation to intestines. Under that umbrella can be constipation and or loose stools, mucus in the stool, gas, abdominal bloating, nausea, whereas Crohn's is a disease and can cause destructive inflammation to the intestines and has more common symptoms of frequent urgent bowel movements, bloody diarrhea, abdominal cramping, weight loss, fever, and nutrient deficiencies. The diagnosis of Crohn's requires a combination of clinical, laboratory, endoscopic, radiologic, and histologic findings. Endoscopy, particularly ileocolonoscopy, is the gold standard and reveals characteristic skip lesions, mucosal ulcerations, and the cobblestone appearance of the mucosa. Biopsies may show non-caseating granulomas, transmural inflammation, and architectural distortion. Cross-sectional imaging with MR enterography or CT enterography is crucial for assessing the disease's extent and complications, such as abscesses, strictures, and fistulas. A small intestine contrast ultrasonography is increasingly used for postoperative surveillance and shows high sensitivity for bowel wall thickening and lymphadenopathy. Lab markers such as elevated C-reactive protein, elevated ESR, anemia, hypoalbuminemia, and elevated fecal calprotectin levels, as well as serological markers. These have limited diagnostic value, but may aid in distinguishing Crohn's disease from a similar disease, ulcerative colitis. In cases of suspected stricturing disease, video capsule endoscopy is cautiously used, but can be used, and that's due to the risk of capsule retention.